Well, good morning, everybody. Thank you for joining us. And I think more people will be joining us, but it's a great pleasure today to introduce one of our medical students, Madison Esposito, who is going to give our Grand Rounds presentation today. Madison has an exceptionally impressive CV, so I'll try to summarize it briefly. After graduating from Oregon State University, she went to NIH for a post-bac intramural research training award fellow. And she worked in 3 institutes there, NIAID in the vaccine research branch, something I didn't know existed at NIH, the Tribal Health Research Office, and finally at the Genome Research Office. And then she went to Harvard to the Chan School and got a master's in public health. And during the MPH, she worked in New Mexico at the Department of Indian Affairs there, where she worked on a project which she completed with indigenous health leaders. And it was a report on for the which was shared with the Secretary of Indian Affairs. And then she went to medical school here at the University of Minnesota, where last year, from 2020 to 2024, she did a post-sophomore fellowship at the Brigham and Women's Hospital in Boston. So she has 4 publications and 2 poster presentations, or 2 presentations already. And she is the co-founder of the International Coalition for Culturally Sensitive Death Investigation. So this morning, she's going to talk to us about investigating sudden unexplained infant death, multisystem approach. So thank you so much, Madison, for doing this, and we look forward to your presentation.
Good morning, everyone. Thank you so much, Dr. Powell, for that wonderful introduction. As Dr. Powell said, my name is Madison Esposito. I'm a 3rd-year medical student. I'm also a member of the Berry Creek Rancheria of Maidu Indians of California. The subject I'm presenting to you today, sudden unexplained infant death, is an issue that is very near and dear to my community as it impacts us so deeply and critically. Today, we're going to explore a multi-system approach to investigating and documenting these cases as a way to see how all pathologists can contribute to further understanding the sudden unexplained death of our children. So our learning objectives today include looking at key neurologic, respiratory, and cardiac and genetic factors that contribute to SUID. We'll explore the latest recommendations on evaluating, documenting, and reporting SUID in the context of forensic pathology. And then we'll explore some case-based strategies for the prevention of SUID within Native communities. So the outline of today's talk will begin by looking at a case study, which we'll use to ground our understanding throughout this presentation. We'll quickly cover the history of SUID. We'll dig into the pathophysiology of SUID, and then we'll talk about public health strategies for SUID prevention. Once again, these will be specific to Indigenous contexts. So for our case study, we'll be looking at a 2-month-old, previously healthy male infant who was born at 35 weeks to a 25-year-old Gravida 2 Para 2 mother by uncomplicated spontaneous vaginal delivery. This infant was found by his mother at 5:30 a.m. in his crib, prone, face down, and unresponsive. When reviewing the events leading to the death of this infant, the mother reported that he had been breastfed at 2 a.m., and then she placed him in the prone position with his face to the side in his crib, and this was because she was concerned that he might spit up and aspirate if he was face down. Then in the morning, the mother found him unresponsive, face down, but still in the prone position. In a scene investigation, using what's called a doll reenactment, revealed a crib with bumper pads and a blanket in which the patient had been wrapped. At autopsy, there was scattered thymic petechiae noted, but it was otherwise considered negative. The manner of death was returned as undetermined, with accidental asphyxia as a possible contributing factor, and it was ultimately signed out as SUID. So before we dive into the history, epidemiology, and pathophysiology of SUID, I'd like to offer some quick definitions to help us frame this phenomenon. So we'll begin by reviewing the classification of cause, mechanism, and manner of death as used in forensic pathology. The cause of death identifies the specific injury or disease that directly leads to death. The mechanism of death explains the physiological process that ultimately results in the fatal outcome. Cause and mechanism of the death are derived from medical records and autopsy findings, so the biologic findings within the death investigation, while the manner of death takes these details and considers them in the context of the circumstances surrounding a death. So this includes the medical legal investigator reports, scene investigation, and other material evidence involved in the event of death. The manner of death is typically divided into natural, when there's a clear disease process implicated in the precipitation of death. These are things like widely metastatic carcinoma. Unnatural, which is further divided into homicide, suicide, and accidental. And these distinctions depend on the circumstances and specifically the intent surrounding the unnatural event leading to demise. And undetermined. Undetermined is declared when there's no indicative findings on autopsy and the evidence at the scene cannot be clearly connected to the culmination of a death. SUID is categorized under the undetermined umbrella, as the definition for this phenomena is the sudden and unexpected death in an infant or a child that was thought to be in good health or whose illness appeared to be so mild that the possibility of a fatal outcome was not anticipated, and autopsy and forensic investigation yielded no compelling manner of death. So this is our understanding of SUID today, but it wasn't always. The history of sudden unexplained infant death is marked by a progression of scientific inquiry and evolving understanding of the phenomena. It was originally termed crib death or cot death, and cases of sudden and unexplained infant deaths were documented as early as the 18th century, where rates of SUID were 462.9 per 1,000 births, with 46% of children dying before their 5th birthday. In these times, SUID was poorly understood, and unfortunately, mothers bore the brunt of this crisis. Courts in this time considered SUID to be homicide, and mothers were pointed to as the perpetrators. Their reasoning was that many of these cases, mothers were found to have overlaid their infants, inadvertently smothering the child while sharing the same sleep service. The punishments were fierce, with reports that Egyptian women found guilty of overlaying were required to hug their dead infant to their side for 3 days and 3 nights. It wasn't until the 19th century that medical professionals began to recognize the complexity of SUID and its distinction from deliberate acts. Although SUID was still firmly thought to be unnatural at this time and categorized as accidental mechanical suffocation, the physician scientist J.H. Kopp went against his contemporaries by developing a theory that pointed to a natural cause of SUID. In his proposed mechanism, which he called thymic asthma, Kopp had unfortunately mistakenly identified the thymus, which is much larger in infants, but basically gone by the time a person is in their teens. He saw this as an abnormality that had led to strangulation within the infant internally. And although this theory was proven faulty a decade or so later, it encouraged other physicians to study SUID. And soon reports of respiratory illness and bacterial infections as major causes of SUID emerged. However, in all of this research, scientific inquiry around SUID was still only considering the intrinsic factors involved. At a forensics conference in the 70s, a panel of 27 pathologists established the bare minimum for investigating the sudden death of an infant, and in this included the importance of scene investigation. Pathologists then began recognizing the multifactorial nature of SUID that included both intrinsic and extrinsic contributing factors. After this, studies from across the country began identifying prone position as a commonality between cases of sudden infant death. The connection was so strong, in fact, that public health interventions were begun to roll out, urging patients to put their babies to bed on their back and avoid prone sleeping position. So I have here a chart showing the precipitous drop in SUID following the largest public health campaign to prevent prone sleeping, which many of us may be familiar with. It was called the Back to Sleep campaign, and it was launched in 1994. I really want to make sure that I point out, however, that there's a discordance here between the continued decline seen in what was called SIDS, or sudden infant death syndrome, shown here by the blue line, and SUID, shown here by the purple line. I point this out because there's a real difference between these nomenclature, and it has caused a lot of confusion in documentation and data reporting. The term SUID was introduced in 2010 when forensic pathologists began recognizing that SIDS was an overly broad and misleading term. There's no real unifying and discrete syndrome that has been causing these cases of unexpected infant death, and the use of SIDS has confused the public and muddied death reporting by obscuring other causes of unexplained infant death. And this SUID was agreed upon as the appropriate nomenclature, although the term SIDS still persists in a very real and complicated way. So let's talk about that just a touch more. So here's a graphical breakdown of how SUID falls within the framework of the manner of death. We can see that there are explained unnatural and explained natural manners of death. And then there's undetermined natural and undetermined unnatural cases. It's in this overlap of undetermined cases that SUID exists. These cases are so solidly within the realm of undetermined due to the paucity of evidence seen in both autopsy and investigation. Death reports of SUID cases have been further broken down in the ICD-10 system as, unfortunately, SIDS, a truly unknown case, accidental strangulation or suffocation. And for those unfamiliar with classifications used here, they're not made by the medical examiner or the forensic pathologist completing the report. They're instead designated by a third party, which is called a nosologist. So this means that the distinction between these identifiers can be up for interpretation depending on how the physician filled out the death report, but they remain under the umbrella of SUID. And I'm sure many of you noticed that SIDS is still here, sudden infant death syndrome. A lot of effort by forensic pathologists have been made to change this coding, but this struggle is still very much underway. So although there's been an overall decrease in SUID across the country, certain demographics continue to suffer disproportionately from this crisis. So I have here a chart of SUID cases per 100,000 live births from 2016 to 2020. Showing that SUID rates in American Indian Alaskan Native babies was 213.5 per 100,000. That's more than double the national rate of 92.2, and it's in fact higher than the national SUID rate before the Back to Sleep campaign even started. These statistics are horrifying, and to properly address and intervene in the further deaths of children in all communities, we must better understand SUID and the events that lead to its occurrence. So let's do that. Today's approach to studying and understanding SUID comes from the triple risk model, which was developed in the 90s by researchers J.J. Filiano and Hannah C. Kinney. In this model, the authors propose that SUID arises in infants within the critical development period of 0 to 6 months, the infant has some pre-existing vulnerability, such as infection or illness, an abnormal brainstem, a cardiac conduction problem, ion channel abnormalities, a genetic predisposition, or was born premature. And then the vulnerable developing infant is impacted by an exogenous stressor, such as co-sleeping, prone position, overheating, a poor sleep environment, exposures to toxins like tobacco smoke. Ultimately, these factors contribute in a context that produces SUID. We'll begin by discussing the critical development period. And we're going to further characterize this period by looking at some death reports. So we can see here in this chart reporting sudden unexplained death separated by ages from 1 to 18 years old, that in 2019, there were 203 deaths within the 1 to 4 year range, accounting for 56% of deaths recorded in this data set. When we focus on the first year specifically, we see even more clearly the overrepresentation of unexpected deaths within the early weeks of life. And there's a peak right here around the 10th week of life specifically. There's so many physiological changes occurring within this time period, and this dysfunction of these systems has been hypothesized to be the causative factor in SUID, but there has not been one specific thing found as the most indicative. But let's cover a few here. So during the first year of life, the volume of the human brain's white matter increases by around 16%. I have shown here the timeline of myelination of the corticospinal tract as an example. In this tract, like many others developing in the brain, we see significant myelination during the first 6 months of life. During this time, conscious movement and coordination in the infant, such as rolling over and lifting their head, are developing. Lung development is also underway in this period. Although airway branching is complete at term birth, more than 90% of alveoli are formed from birth to 8 years. Vascular development within the lung also parallels the alveolar development process. And cardiovascular systems are experiencing dramatic augmentation as the infant adapts to its postnatal environment. So let's discuss some of the exogenous stressors implicated in SUID. So in a study by the triple model authors, the following factors were identified as significant risk factors in SUID cases. These included co-sleeping, prone position, poor sleep environment, and maternal smoking. As I discussed earlier, co-sleeping has long been implicated in SUID and manifests in events of overlaying the infant. Although not the highest in this data set, prone sleeping is reported in 30 to 50% of SUID cases. Elements of poor sleep environment, such as soft bedding, sleeping on a memory foam mattress pad, or sleeping on a couch, are thought to lead to SUID by physically occluding an infant's airway. And then maternal smoking is linked to SUID in what could be explained as a less tangible way than the other factors listed here, although it's been hypothesized that its most significant impact is on the actual prenatal development of the infant. In this study that I'm citing here, actually, they hypothesized that maternal smoking and in utero nicotine exposure had its greatest impact on SUID through impeding brainstem development. And this is something we'll dive into much more later in this presentation. In addition to these factors, many studies also associated overheating, either due to fever or high ambient temperature or overbundling, to SUID. All right, so let's revisit our case study from the beginning with our new knowledge about exogenous stressors. I have here an example picture of what's called a doll reenactment. So it's typical for forensic investigators to use doll reenactments in the context of sudden infant death investigation. A doll reenactment is a forensic tool used to recreate the position and environment in which the infant was found. Investigators use a doll similar in size to the child while they ask caregivers to demonstrate how the infant was last seen and last discovered. This helps identify sleep-related risk factors and improves the accuracy of scene documentation. And although it may sound morbid to go through this with caregivers, many caregivers have reported catharsis from the process. So when we look at these pictures, this isn't exactly the case, but it is a similar case to our study. We can see that this is a baby that had been placed in the prone position with his face to the side when originally put to sleep. And he was found in the prone position with his face down in the mattress in the morning. For our case, there was no recorded bed sharing, no exposure to tobacco smoke, there was no overheating documented, but the prone position and poor sleeping environment do overlay with the identified exogenous risk factors for SUID that we had identified earlier. So let's look more closely at how the prone sleeping position and the different theories on why it could lead to SUID. Contrary to what our mother in the case study believed, prone sleeping places the esophagus above the trachea, which increases, not decreases, the risk for aspiration. Infants between the ages of 6 weeks and 4 months are also considered obligate nose breathers. And so the obstruction of the nasal passages in prone position has been pointed to as a major factor contributing to a possible asphyxial death in these cases. In addition, rebreathing of exhaled air with increased carbon dioxide and reduced oxygen concentration levels can occur while the infant is in this prone position. This position has also been linked to unimpeded low blood pressure, compromised cerebral blood flow, altered cardiovascular capacity, and increased body temperature. Even in healthy infants, they see reduced arousal in this position. This is, in fact, a reason why so many parents opt to put their children in prone position, because it causes the baby to wake up less easily, and so they sleep longer. I have here a diagram of the proposed process and how rebreathing in the prone position can lead to SUID. When prone, the buildup of CO2 and depletion of oxygen causes hypoxia, which in a healthy infant evokes a simultaneous large biphasic inspiratory effort, which is essentially a very big fancy term to say an augmented breath or a sigh, and a startle reaction. The sigh increases mean arterial pressure and arterial PO2, while the startle reaction causes a neck extension and it dilates the upper airway. These reflexes result in normalization of breathing and ultimately rescue of the infant. In vulnerable infants, however, these reflexes are not triggered. And so when the infant becomes hypoxic, they fail to lift their head from the sleep surface. And so in the absence of arousal, a hypoxic coma occurs and bradycardia develops. In some cases, gasping does occur and has been seen on video monitors, but still there's insufficient autoresuscitation and the infant silently passes. Some anatomical findings associated with higher risk of SUID due to rebreathing or asphyxia in the prone position include facial abnormalities such as retroposition of the maxilla, narrowing of the nasal passages, or enlargement of the tongue. All right, now let's examine some of the vulnerabilities that may lead to SUID in the context of prone position specifically. So in a 2020 review of intrinsic and extrinsic factors associated with SUID, we see several intrinsic factors accounted for. First, 70% of cases had findings of immune or infectious factors. 43% had neurologic factors, and 40% had suspected pulmonary pathology. To a lesser extent, they saw genetic and cardiac factors present at post-autopsy. So we're going to discuss the neurologic, pulmonary, and cardiac findings that are associated with SUID cases, specifically within the context of prone positioning. We'll start by discussing the neurologic findings. The most studied of these findings is the dysfunction of the medullary serotonin system. Serotonin is produced in the brainstem and has been extensively linked to respiratory regulation in SUID cases. In fact, synaptic projections from serotonergic neurons are present in all of the major respiratory nuclei. Dysfunction of this system has been implicated in by some counting, up to 70% of SUID cases. Within the central nervous system, serotonergic neurons are located in the brainstem in either the pons and midbrain, labeled here in purple is the rostral domain, and the medulla, labeled here in blue is the caudal domain. As we follow the arrows in this depiction, we can see that the rostral domain projects throughout the cortex, while the caudal domain projects to sites within the brainstem and spinal cord. The rostral domain plays a significant role in cognition, cerebral blood flow, and mood, while the caudal domain is involved in respiration and autonomic regulation. It's this caudal domain that has been most implicated in SUID-related pathology. In this accompanying diagram, we see the major serotonergic nuclei highlighted in red, such as the arcuate nucleus, indicated here, which is involved in chemoreception and breathing control, and the nucleus giganticellularis, which innervates the caudal hypoglossal nucleus, which is shown here in blue. It's been proposed that the overall function of the medullary serotonergic nuclei is to modulate and integrate autonomic and somatomotor control in accordance with an individual's level of arousal and or brain pH and carbon dioxide content. To put that in other words, these nuclei and their proper functioning are critical for a sleeping infant to rescue itself from a hypoxic state. All right, so in a 2003 article by Hannah C. Kinney, one of the authors of the triple model, she looked at serotonergic brainstem abnormalities specifically within Northern Plain Indians whose deaths were reported as SUID, which was then called SIDS. So you'll see SIDS throughout these graphs. So in this study, they used 3H-LSD, which binds to several serotonin receptor subtypes to measure total binding in the major serotonergic nuclei implicated in SUID cases. They collaborated with the Aberdeen Area Indian Health Services to compare a sample pool of American Indian SUID cases to non-American Indian SUID cases, as well as controls from both populations. They looked at individuals aged from 40 to 90 weeks post-conception. In this chart that I show here, we can see that binding in the arcuate nucleus in both populations of SUID infants was significantly lower than in controls across the same time period. In this chart, we look at binding in the nucleus giganticellularis, which, as I said, innervates the hypoglossal nucleus. And we see that there's a temporally linked decline in 3H-LSD binding across the represented time periods. This interesting pattern was also seen in other nuclei of the serotonin system, but to a lesser significance. In hypothesizing on the reason behind this finding, the researchers commented that baseline developmental studies have shown that there's a significant decline in serotonergic receptor binding in these nuclei from high levels at mid-gestation to low levels around term birth, with a sustained low plateau across the first year of postnatal life. The decline from high to low binding levels in these same regions in the SUID cases may reflect delayed maturation in this binding pattern, with a shift from the fall being during the appropriate period during mid-gestation to birth to an inappropriate period between birth and the end of the first postnatal year. Alternatively, this distinctive pattern of binding may reflect adaptive changes in SUID cases, with receptor upregulation around birth, followed by decompensation and regulator downregulation over the first postnatal year. Other studies have suggested that during REM sleep, there's a decrease in activity of serotonergic neurons, allowing for disturbances in their respective systems to occur in a child already vulnerable to SUID. Adding to the massive complexity of this issue, there's marked changes in conscious motor control that overlap with the peak period of SUID in this first year of life. And these are suggested as reasons why SUID does not happen to a child who is awake or in an older child when their motor behavior is already well developed. All right, so histology. On histology, there's severe hypoplasia or aplasia of the arcuate nucleus that has been reported in multiple SUID cases. This finding suggests a prenatal cause of SUID that is rooted in dysfunction of proliferation and migration of future arcuate neurons from the embryonic precursor called the rhombic lip. Studies that have sought a genetic basis for this dysfunction of the serotonin system have pointed to variations in the promoter region of the serotonin transporter or 5-HTT gene, which is key in regulating serotonin levels at the synapse. In 2 studies on the subject, researchers reported an increase of the L allele, shown here, in many SUID cases. The L allele is thought to increase the effectiveness of the promoter region of the 5-HTT gene and lead to overexpression of the transporter. This overproduction of 5-HTT results in reduced serotonin concentration in the synapse. The observed decreased serotonergic receptor binding may be due to downregulation of presynaptic autoreceptors in accordance with this overexpression of 5-HTT. The increased incidence of SUID in Native American infants may be related to a genetic polymorphism in this promoter region. However, testing has not been uniformly supportive of this hypothesis. All right, so having just reviewed the role of serotonergic neurons or networks in SUID pathogenesis, I want to highlight one of the most significant and modifiable environmental disruptors of this system, which is maternal smoking. Maternal tobacco use remains a dominant modifiable risk factor for SUID, particularly in the back-to-sleep era. In fact, maternal smoking is now more related to SUID than prone sleeping is because of the effects of the back-to-sleep program. And while national rates show about 13% of pregnant people continue to smoke throughout their pregnancy, in some Native populations, this number can reach as high as 75%. Nicotine readily crosses the placenta, entering fetal circulation and binding to neuronal nicotinic acetylcholine receptors in the brain as early as 4 to 5 weeks of gestation. These receptors are highly expressed during fetal development, especially in the brainstem regions responsible for arousal, respiration, and autonomic tone. Exogenous nicotine may bind to and inappropriately stimulate the function of these receptors, and persistent stimulation by maternal nicotine may lead to receptor desensitization, particularly in these transiently overexpressed fetal receptors, compounding serotonergic deficits in critical medullary nuclei. In addition to neurologic effects, in utero nicotine exposure has been linked to decreases in infant lung compliance and volume and decreased heart rate in response to stress. Once born, infants who are exposed to environmental tobacco smoke are also more likely to develop bronchial asthma and pneumonia, especially in the first 2 years of life. The activity of the serotonin system is not confined just to neural development, but it's also implicated in early stages of fetal lung development. So there's serotonin immunoreactive cells present in human lung as early as 8 weeks of gestation. Strong expression of serotonin receptors have been documented in the endothelium of developing blood vessels and smooth muscle cells of the arterial tunica media of the developing lung across each stage of lung development. However, I was unable to find any studies documenting the effect of the L allele in the serotonin transporter promoter site on the presence or function of these receptors in the lungs of SUID infants specifically. So, you know, possible new area for research if anyone's interested. Genetics continues to be a culprit in other organ system dysfunction related to SUID, particularly channelopathies like the long QT syndrome, which is the most frequent one associated with SUID. Approximately 12% of SUID cases have evidence of long QT syndrome. In a 1991 prospective study, they found that prolongation of the QT interval in the first week of life was strongly associated with SUID in the first 6 months. Although mutations in several genes have been associated with SUID, the majority of mutations have been detected in SCN5A. These mutations either cause an increased persistent sodium channel current or accelerated inactivation of the sodium channel. Furthermore, this is really interesting, SCN5A mutations have been shown to serve as a trigger for arrhythmia during sleep. In this schematic, we see how the exogenous stressor of respiratory acidosis can develop in prone sleeping and produce an increased late sodium current in the context of the SCN5A mutation. The late sodium current causes a prolonged action potential duration, as well as early after depolarizations. And this creates the long QT interval. The long QT interval may culminate in a torsades de pointe arrhythmia, which can then degenerate into VFib, causing sudden cardiac death. When examining the histopathology of the conduction system in long QT syndrome, we can see fragmentation of cardiac fibers with increased fibrosis, particularly in the SA node. In the AV node, fibers appear disorganized, compact, and wispy in comparison to control. The size of conduction fibers were also markedly reduced in both locations, with normal fibers in the SA node being on average 10 micrometers thick, but 5 micrometers at their thickest in a patient with long QT syndrome. The same difference of thickness was also demonstrated in the AV node. The researchers of this study also noted fragmentation, fibrosis, and differences seen in fiber thickness in the bundle of His in the internodal tracts. In all sites, the researchers reported a decrease in number of cardiac conduction fibers as well. These findings are interesting. However, the authors were unable to discern if the differences contributed to the arrhythmia of long QT syndrome or were just a byproduct of the disease. Either way, these histologic findings are useful markers for identifying long QT syndrome as a possibility in SUID cases, especially when genetic testing is not readily available, such as on native reservations. All right. So now that we know what to look for concerning intrinsic factors, let's review the intrinsic factors that may or may not have existed in our case. At examination, there was no airway obstruction, aspiration, or lung pathology. There was no gross or microscopic cardiac findings. Excuse me. Toxicology was clear. The testing for channelopathies came back negative, so pretty much striking out so far. The gross examination of the brain was negative, but microscopic analysis showed arcuate nucleus hypoplasia. Ultimately, however, this case was still considered undetermined, with caveats that the arcuate nucleus hypoplasia in the context of prone sleeping position could be connected to the patient's sudden death. When it comes to preventing further deaths like these in any community, we must focus on what the community itself needs. The Healthy Native Babies program does just this in identifying and attempting to address the cultural and socioeconomic factors that may be influencing SUID within Native communities. So briefly, Native communities have very little access to prenatal care, with over a third of pregnant Native mothers not accessing prenatal care ever in their pregnancy. They have high rates of prematurity, low birth weight, and high rates of bed sharing. And as a quick aside here, when I was making this presentation, I called my mom about it, and she told me that she actually co-slept with me and all of my siblings when we were babies. That's how prevalent it is. 100% of my family went through co-sleeping. Native populations also experience some of the highest poverty rates in the country. And then there's also the issue of non-traditional tobacco smoking among our people. Tobacco is, in many communities, considered a very sacred and important medicine. And when used traditionally, it can be argued that there is not much risk associated with that act. But non-traditional tobacco smoke, commercial tobacco smoke, is very detrimental to both personal health and in utero infant health. The overall Native population has the highest prevalence of smoking commercial tobacco for both men and women compared to any population within the US. Smoking rates can vary considerably between one tribe to another, but according to the CDC, 26% of Native women smoke commercial tobacco during their pregnancy. This is the highest rate of any racial ethnic group. And as I said before, some tribes see rates as high as 75%. This is also a terrible combination of risk factors because due to the low coverage of prenatal and pregnancy care within Native communities and on reservations, Native women are so much less likely to access smoking cessation programming during their pregnancies. And so this issue persists in a very real and very scary way. So to summarize my presentation, SUID occurs in infants who are considered healthy and at no risk of sudden death. It's not a single syndrome, but a phenomena caused by a combination of exogenous stressors, intrinsic vulnerabilities during a critical development period in the first year of life. And finally, public health strategies that encourage babies sleeping alone, supine, and uncluttered cribs have led to significant decreases in SUID rates, but the issue persists, especially in American Indian, Alaska Native communities. All right. Thank you all so much for listening to my talk. I'd like to specifically thank one of my mentors, Rick Mitchell, who was my direct mentor in making this presentation, and also the tireless work of the National Association of Medical Examiners panel on sudden unexpected death in pediatrics. They have a whole textbook on this crisis, which is free, and they offer online CME training, also free, for physicians looking to learn more about SUID and how your work can help end this crisis once and for all. Thank you all so much. I'm happy to take questions.
Thank you, Madison. That was really wonderful, wonderful, and such a complex talk with so many different factors. I thought it was terrific. So do we have questions now for Madison?
Hey, Debbie. Madison, nice to meet you. Andy Nelson. I'm actually faculty in molecular pathology and genetics, and thank you. That was a really cool talk. I apologize. I got distracted a little bit because of a clinical ask that came in my way while you were speaking, but hopefully my question wasn't in part of your talk when I wasn't paying attention. Given the fact that one of my clinical responsibilities is in germline genetics, I kind of was trying to pay close attention to the genetics aspects that you pulled out, the channelopathies. And those research studies, how broadly were the research teams looking? Was this, kind of like whole exome sequencing? Was it really focused on some of the cardiac function, germline mutations associated with cardiac function? Just trying to get a sense of how broad has the look been to characterize potentially other types of inherited conditions that might be contributing to, sudden infant death?
Yeah, no, that's a great question. And I totally understand this presentation's recorded, so feel free to address clinical needs before listening to this. The investigation into channelopathies in sudden unexplained infant death is actually rather extensive. When it comes to practical application, I know that in medical examiners' offices, they will take tissue from the heart of any infant death that they investigate, and they send it out to a pre-made panel of several genes that have been identified. With the research that's out there, the study that I was incorporating into my presentation specifically was only looking at 3 genes within a cohort of highly suspected SUID cases.
Yeah.
And so that's kind of not the same question that you're looking at, but I am confident that there is research out there that really digs in. This is an issue that's been impacting children, families, babies for decades. And so I would have to dig a little bit further into the literature, but I can definitely try to find something for you if you're interested.
Well, yeah, and not even just, again, I mean, you're obviously passionate about this and you have a depth of knowledge that's way
I will
beyond
probably look on my own anyway.
pretty much everyone's. The reason that I thought of it was, a number of years back, we actually had a case. We don't do them often, but occasionally we do end up basically essentially being asked to do molecular autopsies.
Yeah.
Not necessarily in this case, in this specific clinical context, but we haven't had in the past where medical examiner's office in the, Twin Cities area has come to us with a case of, really essentially I would label it neonatal death. And again, this gets into the public health parameters of how you kind of define SUID, but it ended up being a case of ornithine transcarbamylase deficiency. And from a newborn screen,
Yeah.
it was very subtle. And yet the child died, I think, 48 to 72 hours after being released from the hospital. And the variants that we found took us essentially across the globe
Mhm.
trying to get feedback from experts in OTC deficiency, structural insights,
Mhm.
crystallography, all sorts of stuff to try and actually get to the point where we could be confident that this was the actual cause. And I was wondering as you were presenting that part on the channelopathies, like how much else could there
Oh
be
yeah.
in some of these that is part of these metabolic syndromes and other things. And it's challenging to think about, but it's interesting. So I'll yield
Yeah.
the floor to you and John. Thank you very much. It was a nice presentation.
Thank you.
John?
Oh, John, you are muted.
I thought I'd unmuted. Thank you very much for that presentation. I'm of an age where I have actually, unfortunately, experienced a lot of what we called SIDS at the time. I did my training basically in the late 60s and early 70s. And actually, I did spend a lot of time in the medical examiner's office. So unfortunately, we saw a lot of these cases. And I just want to say I'm delighted that the research has gone as far as it has, because it certainly has changed the perspective of what we called SIDS at the time. And it has a real impact, obviously, on society. To have a 3-month-old child die is terrible for the family. So thanks very much for presenting the research that's been done so far, and keep it up.
Thank you so much. Yeah, it is unspeakable how this impacts families. When I actually saw the name panel on Sudden Unexplained Death in Pediatrics present at USCAP last year, and their textbook is made in combination with families who have experienced SUID, and they dedicate the entire book to it. One of the quotes that they have at the beginning of their book has really struck me and stayed with me, which is that the mourning of the death of an infant ends when the parent dies, as a way to say that that loss is going to be felt forever. And making sure that we fully investigate and do our best to understand why this is happening and ways to intervene, building on this research. It is extensive right now, but there's still so much more to know. I mean, in this presentation, after this, I have like 15 other slides of other things that I thought about putting in. I have a slide on the metabolic genetic factors that can implicate and lead to SUID. There's for every slide that I had, there's 1,000 other things that could be connected to this. And it really underscores that this is not just one syndrome. It is a cosmology of understudied, really early in life pathology that is leading to the sudden loss of our children.
So, if there are no other questions, I wanted to ask you, because I was horrified by the statistics in Native children versus other children, and it was just horrifying. And I wondered, what are there campaigns now going on, or could there be, to really carry an education effort among Native communities throughout the country so that they are more aware of some of these factors? Because it seems to me that that's really an important public health issue, to try to get specifically targeted campaigns about this problem to the Native populations.
Yeah, I completely agree. And I think that something special about Native populations is that we see so much from public health research data that targeted interventions that are centered in cultural congruence among Indigenous communities are the most impactful and successful. You can't take something so broad as the Back to Sleep campaign and bring it to Native communities and be, here, this will fix it for you. That's just not how it works. So the Healthy Native Babies campaign, which I mentioned in the presentation, is one of the largest. It's kind of an offshoot of the Back to Sleep campaign, but it is, made to be specific for Indigenous contexts. And then you have public health centers throughout the many regions of the United States that are overlapped by traditional Native reservations and lands, and then also urban Native centers. So I know that the Center for American Indian Health at Hopkins has a special program where they bring in mothers, expecting mothers, and build cradle boards with them. This isn't something I touched on in this presentation, but it is a really important thing. Cradle boards, if anyone's not familiar with them, are essentially a decorated board that a baby is wrapped up and tied to. The mother can carry the baby on their back, or they can set them up to sleep that way. It keeps the baby in a supine, stable position on their back while they sleep. There's not been any formal studies, but the Association of American Pediatricians have supported cradle boarding as a safe sleeping practice that prevents SUID. So that is a huge thing. And I know those programs have been picked up by other public health centers that work with Native populations across the country. There's also many public outreach programming, even within Minnesota, that bring in expectant mothers to places like the Indian Health Board, which is just down the street from downtown Minneapolis, and NAC, the Native American Community Clinic. These are programs that are targeted towards mothers that are at very high risk of having poor birth outcomes, mothers that have prenatal and also during pregnancy tobacco smoking, that are using drugs such as opioids. And they're a way to support these parents throughout that process and try to create a healthier environment for themselves and their children. So there's lots of programs out there, and yeah, I think it's great. I'm hoping that there's more.
That's great. And also, we need to find a way to increase the number of Native American physicians and other healthcare providers, because this is so critical for reaching populations like our Native communities, and there aren't so many. So it's going to be great to have you join the workforce and to join the pathology team. We are really excited about having someone like you as in our pathology community. There are far too few pathologists who are Native Americans. There are almost none. So last time I looked, there were 4 or so.
Yeah, there's about 4.
Yeah.
Yeah, one of my friends, Victoria Thomas, actually from back at Brigham, she's just finishing her microbiology fellowship, and then she will be the 5th.
Oh gosh. And you'll be the 6th.
Hey,
We're
hopefully can be.
Yes. Well, we thank you so much, Madison, for doing this morning. It was really a wonderful talk.
Thank you so much.